Nothing grossly abnormal there. Now, some of you may have spotted that there is a bit of soft tissue swelling overlying the left orbital area. So that's something to keep in the back of our head, that there may be some underlying facial injuries. So the next thing to do is to have a look at the bone windows and try and take a closer look and see what's going on with the rest of the bones. So scrolling from the top, scrolling down, scrolling down, scrolling down, scrolling down. Haven't seen anything grossly abnormal at first. And then as you come down to the sort of nasal area, yep, you can actually see that there are some nasal bone fractures over here. They don't look normal at all. For those that can't see that, let's just sort of bring that to the middle and then zoom in a little bit further and then scroll again and have another closer look. So yeah, there are multiple nasal bone fractures, and that may be the cause of some of that soft tissue swelling overlying the orbit. The orbit itself doesn't look like it's been fractured. It doesn't look like there's any obvious zygomatic arch fracture. And the maxillary sinuses, yeah, there's a bit of thickening, but not much in the way of anything else going on within that region over there. Now, the best thing really to look for these sort of bony injuries, in my humble opinion, is to not just rely on bony reconstructions, but also try and do something else called MIPPing. So when you've got the MIP like this, it's actually really useful because you orientate things as you are on multiple kind of planes. So you've got your coronal plane, you've got your sagittal plane, and then you've got your axial plane. So the axial plane is the one that we're particularly used to. But then the next thing you want to do here is to come up to this area and try and increase the thickness of your slab, the MIP. And I found MIPPing very, very useful, and actually far more useful than the bony reconstructions that you get in a lot of the software that's available. And the reason being is because a lot of the software will end up smoothing over quite subtle fractures, and I find that doing this is actually a really good way to try and identify fractures. But the next thing you do, you really got to window this so that it actually looks like you're Macbeth and you're holding the skull in your hands. Let's zoom in a bit more just so we have a really good look around. I've windowed it so that I can see a little bit more of what's going on. So now we come up to we're coming up to the back there. What we want to do is come all the way to the front and have a look at these facial bones and try and see if we can see any sort of obvious fractures, because as we know, they had a bit of a fracture overlying their nasal structures over here. We haven't seen anything grossly abnormal. Everything looks okay. And the next thing you want to do is use the other planes to sort of reorientate yourself just to make sure you've got a really good sort of AP view. But actually, when you look at this, the facial bones don't actually look too bad. There's no obvious fracture there, but something does kind of creep out, and there's this little area over here. This does not look normal at all. This is going to be in keeping with what looks like a bit of a focal fracture. So let's have a look at the initial images and see if we can find that area again. So let's come up. And there, can you see just at that area there, I'm going to put a little arrow there. There's a little tiny locular vein that is located there. And there's a kind of inward bowing of some of the bone just in that area. So what's actually happened here is that because the curvature of the skull is not immediately obvious, that there's actually a fracture with a few fragments of bone that have come inwards. And so there's a few ways to pick this up. I mean, if you're going to do it in sort of the check areas way, I would 100% recommend using a lung window just to make sure there's no evidence of any pneumocephalus. And in this particular situation, there is some pneumocephalus sitting there, and it's far more obvious when you look at it on the lung windows. So genuinely, with every single scan that I do these days, I always check the lung windows. Lung windows are a really great systematic way to look for any pneumocephalus or anything that could be out of the ordinary. But then also I do find using that 3D reconstruction, i.e. the MIP images, to be very, very useful. But I think that's a really interesting case because it kind of, at first it doesn't look like much going on, and you get really focused on the face because you've got lots of swelling in the face and you kind of got that risk of satisfaction of search and you haven't seen any particular fractures. But I genuinely think that the 3D reconstructions and the lung windowing is going to be very, very useful for anyone going forwards with any sort of traumatic cases, and it's helped me out a number of times. So hopefully that hasn't made your head spin too much. We're going to go on to the next case. So this is a CT scan of an adult patient, and they came in with long-standing headaches. No precipitating factors. It wasn't thunderclap or anything like that. So let's have a look. This is a non-contrast study. Let's scroll all the way through. And at first, it doesn't look like there's much going on. Yes, they've got a bit of involutional changes. They've got a little bit, maybe some small vessel disease as well. But again, I haven't seen anything grossly abnormal in terms of any acute abnormalities. I remember this person did say they've got headaches. So we've got to start looking at the sulcal spaces, try and see if there's any evidence of any subarachnoid bleeds anywhere. So they can be quite subtle subarachnoid bleeds. So I do specifically ask myself to keep looking, keep looking, keep looking. And in that pre-pontine area, there's been a few occasions where there've been slow bleeds in that area as well. But again, I haven't seen anything grossly abnormal with regards to the appearances of the actual brain. And now this is when you've got to start thinking about the check areas and the check things that I would do. So one of the things, even though this is not a trauma case, would be to go through the lung windows and have a good look through the lung windows and make sure there's no obvious locules of air anywhere to kind of throw up any surprises. Now, nothing's come up on that, so let's go to the bone windows, make sure there's no destructive bone lesions. For those that don't know, these sort of areas over here, they're not going to be the sort of lytic lesions that I've seen. I had a few registrars ask over the years. They're actually fairly normal. They're going to be venous lakes that are very, very common within the cranial bones themselves. But coming further down, yeah, you can see loads of that, but a normal trabeculation, but no evidence of any fractures at all. So things are still looking pretty good. Still, things don't look too bad at the moment. We're thinking we might let this person go home. But I think we should do the MPR imaging as well. And the MPR imaging is very, very useful just to have a good look through and see if there's anything that we should be worried about. Let's go from front to back, or AP. And again, nothing grossly abnormal. Sometimes a good idea just to have a look at these mandibles as well, just to make sure there's no bilateral or unilateral dislocations. That has happened in the past. And then scrolling through from side to side, see if you can find anything abnormal, kind of going across, and everything looks like it could be relatively okay. So at first we're thinking it could be okay, but actually when you come up to this level here, around there, you start to notice that there's something not quite right. And the area that's not quite right is going to be this area down here. See the odontoid peg, this sort of atlantoaxial region. It looks very sort of out of line. You've got your lateral process there, and then you've got your C2 vertebral level over there. And that just does not look right. It looks like it's very sort of abnormal in terms of its orientation. Scrolling through now, as you look, you can see that actually, yeah, this area over here, this foramen magnum, the foramen magnum looks okay, but this is also pushed backwards that way. And there's also very, very much of a narrowing involving the spinal canal over here. So this looks very abnormal. It doesn't look like it's traumatic. It looks like it's been there for quite a while, but it does look like there's some sort of extensive soft tissue area over here, but no evidence of any destruction over there either. So some sort of soft tissue area there that is resulting in sort of mass effect that way and causing significant narrowing of the skull base. Now, if we come back to the bone windows, it does look like, yeah, this does not look like it's nicely lined and almost looks like it's all shifted completely out of place. So we're worried about an atlantoaxial subluxation, and in a non-traumatic situation, this could be caused by a few things. It could be gout, it could be rheumatoid arthritis as well. Now, this person actually did end up getting an MRI scan, and this is the sagittal views, and again, you can see how narrowed that spinal cord is, how stenotic that particular region over there is. And you can see that, yes, there is a sort of soft tissue stuff sitting right in front of the odontoid peg, causing that mass effect that we were talking about earlier. See if we can find it on the axial views. And on the axial views, you can see it again, this stuff that's sitting over here. And so it turned out to be a rheumatoid pannus that was causing that particular appearance. So this is a really important thing. Again, another one of those sort of satisfaction of searches, and you can completely imagine how you've got lots of CT heads coming in. There could be that time constraint that's going on, and you've got all these CT heads, and then this says, okay, long-standing headache, and it looks like there's nothing going on. And then you just move on. But this is why I think it's very, very important to use the MPR images. Do all the checks, your lung windows, do your bone windows, and use the MPR images as well to make sure that you don't miss anything. And the C-spine, literally, that was last slice, as it were. And so, the last slice could be like the slicing of your career. So I would highly, highly recommend that you don't fall down the satisfaction of search area where you've thought everything's normal and then there's actually something quite abnormal located in the last few slices. So I know last time I did the Everlight talk, I did a fair bit on C-spine. So if you're up for it, then please go check that C-spine lecture out. I'm going to bring a C-spine into this, though, just because we're here and we're doing some emergency imaging. And what kind of emergency imaging talk would this be without going through C-spine imaging? So that talk will go a lot more in depth of how to actually orientate yourself and all that kind of thing. But this is more of a near misses thing that would be quite interesting to go through. So first off, we've got someone here, and if I remember correctly, they had a traumatic injury And the team they weren't worried about the brain, and they weren't worried about the brain at all, and they wanted only the C-spine images to be done. And so this patient came through to get the C-spine images. So what we have here are the sagittal images. And if you scroll through from the sagittal images going all the way across like so, it's very, very important to make sure that everything is nicely aligned with one another. And you see that, yeah, everything looks nicely aligned, and some of you may have spotted the abnormality already, but that's fine. We're going to go through it all together anyway. Scrolling through, everything looks okay. Doesn't look like there doesn't look like much in the way of malalignment. But then there is this sort of abnormality located here and a bit of an abnormality located here. So it's quite worth sort of zooming in and try and see what's going on here. So this area over here looks very well ossified. It looks like it's very well corticated. This doesn't look like a traumatic injury, but this over here doesn't look like a traumatic injury either. It looks like it's coming off the anterior inferior cortex of that vertebral body. It could be some emerging osteophytosis. You can get bridging osteophytes that go across like this. Occasionally you have bridging osteophytes that actually are bridged and then as a result of trauma end up getting a fracture. So it's very, very important to make sure the edges are very, very corticated. Now this one over here does not look right at all. It doesn't look like it's very well corticated, particularly in its more superior aspect. It actually does look like the vertebral corner's kind of been pulled off that way. So if something's been pulled off that way, this patient might have had a hyperextension injury, which therefore made this a hyperextension teardrop injury, making the person cry. Now, this is something to think about. So now if you end up having someone that has had a hyperextension injury, you're going to get a lot of crowding of some of the more posterior structures. So now if we zoom out of this one and have a look at their posterior structures, we can see that, yeah, there are fractures of these sort of spinous processes, right? And some of the fractures go all the way through to the pedicle as well. So you can see that's going to involve the facet joint on this side, coming across into the spinous process and comes across this way as well. Same thing as the one over here. Looks like there's a fracture over there as well. Looks like a spinous process has been affected. So we're thinking to ourselves, okay, great. Okay, well, not great for the patient, obviously, but we can see that clearly had a hyperextension injury, and you've got what looks like quite extensive fractures of the spinous process as well. Now, coming up to the soft tissue windows is very, very useful because you can actually see there is a lot of soft tissue edema within this area. So lots of the muscles look sprained. So if you look at this side, not much in the way of loss of the fat planes. But if you come up to the other side, there's lots of loss of the fat planes, of lots of edema. So they may have actually not just done a straight hyperextension, they might have done a slight curved hyperextension, which has resulted in a slightly more injured one side compared to the other. So it can be tempting to be like, okay, great, we've got the fracture and that's fine. But remember, this is a traumatic injury and it is quite important to make sure that you looked at everything else. So this is why, again, I'd highly recommend looking at the lung windows. Looking at the lung windows, you can try and see if there's any air located within the spinal canal. Haven't seen any air located within the spinal canal, but scrolling through, you start to notice that there may actually be some air located within the cranium. Let's zoom in and have a look. So zooming in, yeah, there's a loculum air located there, loculum air located there. Can we see if there's any more? And just try and pound this away a bit and just try and have a look around, see if there's any other locules or air anywhere else. Not there. Come across to this side. Yeah, and there as well. Can you see that? There's a few locules of air with a significantly opacified mastoid air cells. So coming back to bone windows, you may be able to pick up a fracture within this region, but what you can say is there's also pneumocephalus and significantly opacified mastoid air cells. You would be worried about this person having a skull-based injury and therefore recommend potentially completing a full trauma scan. So some really good learning points there. And so again, this could be one of those situations where satisfaction of search and complete focus on the C-spine fractures, the fact that it was a hyperextension injury, the multiple fractures of the spinous process as well, could really get you focused on that and then not really look at the check area. Okay, so the next case is a young 22-year-old lady who was unfortunately attacked with a knife, multiple stabbing injury, and they came into our CT scanner. This is a full trauma scan, and what we'll do is go through it. You can see that there is what looks like bandages, possibly in the posterior aspect of the head there. Coming down, you can see this is a contrast study. And let's just kind of scroll through together and try and see if we can find anything grossly abnormal. The first thing that starts to come into view are these multiple areas of air located within the fascial planes, within the region of the back. There's a few locules of air located within this region over here, so got to start worrying that some of these are going to be quite significant injuries. Coming further down, we can see that there is what looks like contusions. And now you've got this shimmering thing kind of coming out across this way, all the way across like that. That doesn't look great. And then you've got this consolidation, quite high density stuff sitting over here. Just like a chest drain, okay, well, fair enough. And coming through, that liver doesn't look great at all. That liver looks very, very, very abnormal indeed. Looks like it's very hypodense in appearance. And some of those vessels, let's see those vessels. So part of the grading of liver injuries, if you don't know, is there is a really great grading of liver injuries, which is known as the American Association for Surgery of Trauma Liver Injury Scale. And it kind of just goes through grades. And what I'll do, I'll put it on the screen here so you can actually see the grades. With this one, it looks like there's quite a lot of involvement, right? You can see there's quite a large section of liver that's associated there. There's going to be some, it looks like there could be some biliary injury there. It looks like it goes all the way through to some of the vessels as well. Now, the portal vein, that looks okay. So this is probably going to be affecting the hepatic vein on some level. Now, that looks like there could be some hyperdense material located just at the inferior tip of the liver as well. So that's not great. So there may be bleeding within that region there. The kidneys, they look okay, don't they? Don't look like there's much going on. And the spleen looks all right as well. It doesn't look like there's any splenic laceration. Now let's keep scrolling through and try and see where there's any abnormalities located in the abdomen or pelvis. It doesn't look like it, but there is this sort of fluid located within the pelvis, and there's quite a lot of it too as well. So considering that what they look like have got a significant injury of their liver or laceration of the liver, it's not surprising they've got such a significant amount of what looks like could be hemorrhage located within the region of the pelvis. So this is all not great news for this patient. So the next thing we need to do is have a look at the lung windows, because we haven't done that yet. So lung windows look like so. And okay, on top of that, we've also got what looks like a pneumothorax. And again, the multiple locules of air and the sort of shimmery thing that's going across like so. And that looks like it extends all the way through into the right breast. It's just not a great situation for this person, this poor person, unfortunately. Right, so there, it looks like they have been stabbed from the back, and this actually is the knife that is still stuck inside the patient's body, gone right across the right hemithorax, result of that pneumothorax. Probably got a bit of hemothorax, and you've got lung contusions as well. Now, coming up to the abdomen and pelvis, can't see much in the way of free air at this present time. So we're not thinking there could be a perforation or a laceration of any of the bowel. Right, so then we come back up to this area over here. We can see that shimmery thing, which looks like a blade of a knife. And let's zoom in, because now we can actually see that there does look like there's sort of malalignment of that rib over there. So it looks like there's a bit of a rib fracture as a result of that big knife thing that is sitting there. So, okay, that's terrible situation. So we've got a person who's got multiple stabbings and got subcutaneous emphysema. They've got emphysema in the fascial plane between the muscles. The knife is still in situ. And you've got a high-grade liver laceration and what's likely to be a pelvic hematoma. So again, this looks like we've done what we can for this patient. But actually, one of the things I want to bring your attention to is when you come back to the brain area over here. And like we said earlier, it doesn't look like it's too bad actually. But as you come further down, there's a few locules of air here. You can see that. Coming further down, a locule of air located here and here. Further down, there's locules of air that are located within the spinal canal as well. So now you think to yourself, okay, why have they got like lots of air located within the spinal canal and also within the actual intracranial cavity as well? And this is the unfortunate thing. So this patient woke up and then were complaining of leg weakness, and it turned out that one of the stabbings went across the spine, across the back, and across like this, and all the way through into the actual spinal canal. And they actually had a full-on laceration of the spinal cord itself. You actually see a few locules there just located in the region of where that wound was. And you can see a sort of plaster over the back here as well, and that trajectory that may have been. So this is a really unfortunate patient. I think they actually recovered fairly well, considering the injuries that they had. But the thing is, like, the reason why I thought this was an interesting case is because there is so much going on in this case. But it's like that kind of finishing off stages that people really need to do. when you actually go to the check areas where you do the sagittal views, the axial views, and definitely check the lung windows as well. Like lung windows seem to be the key to be able to pick up some of these more subtle abnormalities. But coming up to the next case, this is a lady who has come in with right iliac fossa pain, query appendicitis, and I'm sure as anyone who does any sort of acute imaging, you're going to get a lot of query appendicitis that come in. So let's have a look at this one and see what's actually happening. So we can see that this is a contrasted heart study. Scrolling through, everything looks like it's relatively okay. It does look like the patient's breathed a fair bit, which has given these sort of double imprint images, right? So they look like the upper diaphragm is moving quite a lot. So they may be in a lot of pain, or they may be very septic, and that's what's causing this appearance. Coming down to this area, all of a sudden you start to notice that this doesn't look quite right, does it? This all looks very, very abnormal. Located right in the depths of the right iliac fossa as well. So this looks like it could be a slam dunk appendicitis. Let's have a look and make sure that this is definitely the case. So let's go to the bowel, and we just follow the bowel upwards, 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 coming across. We're over here right now, over here, keep going, keep going, keep going, keep going, keep going. So we've come up to coming up to the descending colon. This is the descending colon over here. Let's come up, come up, come up, come up, come up, come up, come up. That looks okay so far. We're going to the transverse colon now. Coming across, coming across, coming across, coming across. It all looks all right to me so far, coming right down to the very, very bottom. And again, you know what? It looks like it's right iliac fossa pain. We'd go for appendicitis, but we should really make sure, shouldn't we? Because on the off chance it's not. I mean, what else could it be, right? So now when we look at this area, you can actually see, you know what? There is a tuber appearance to this. It looks like this, it looks like this. This is a massive fat appendix that's got very, very inflamed. It has to be appendicitis. But as you kind of follow that, this kind of goes round like this and kind of becomes like a snail-like thing. Can you see that? It becomes like, goes around like this and does this. Let's follow that. Let's go like that. Does this all the way around like so and all the way around like so. Yeah, this does not look normal at all. It looks like the appendicitis kind of curled in on itself, and then it kind of does this way, this way, this way, and starts to go towards sort of the pelvis area. Okay. So then the other thing to do is try and follow the cecal pole. Let's see the cecal pole that's going to be over here. And then can we find the appendix coming out of the cecal pole? So actually, that looks like an appendix going over there, and looks like there's hyperdense material located within that region over there. Could actually be an appendiculus. And the appendix actually looks like, if that's the appendix, that looks very, very thin, doesn't it? It's kind of going over the top here. Let's follow that along, follow that along. So follow that along, follow that along, follow that along. And it stops. Let's zoom that in just in case no one believed me. Let's zoom in, zoom in. So we were in this area over here. Let's come back. That kind of appendix looks like it's here. It's coming backwards, backwards, curling around like so. You've got a bit of that high dense material there. It's curling around like so, and then into the cecal pole. So therefore, this is not appendicitis. Therefore, this must be something else, something that's tubular, inflamed, sitting within the right iliac fossa or right adnexa. There you go. So this looks like it's actually a tubervarian abscess, and you've got this really sort of interesting snake-like appearance and a snail-like appearance further up, and it all emanates towards the uterus over here. And this is really important, isn't it? Because one minute you're sending this patient off to general surgeons who may go in expecting to find an inflamed appendix, and they've actually been sent to the wrong team, and it ends up being a gynecology problem in the first place. So very, very important to, and I get it, sometimes you're in a rush and you've got a case and it's query appendicitis and you see all that inflammation, the kind of thing, yeah, slam dunk, I'm done, let's go. It's very, very important to be 100% sure. And the way I do it is to make sure that if I think it's appendicitis, I follow all the way along to the cecal pole. I make sure that it goes all the way to the cecal pole, and if it is, then fair enough. But if it doesn't, then I've got to start thinking about what else it could be. Okay, so this next case is a patient who came in and they had left loin to groin pain. So they ended up getting a CT-KUB, which is a non-contrast study looking for renal calculi. And this is the case that we have here. And we can see that this is indeed a CT-KUB because they are lying down on their front. And you can see the table that's sitting over here. Now let's scroll through all the way from the very, very top and try and see if we can find any sort of renal calculi. Now I do concentrate on each kidney at a time. So this is the right kidney over here. Let's scroll through. Coming down to here, we're going to need to zoom in a bit just to try and have a look at that ureter. coming further down, further down, further down. So this looks like it's hyperdense, but actually this looks very, very hyperdense, like metallic artifact. They probably had some previous surgery in the past, maybe even had, these could be sterilization clips as well. Sometimes you get those flying around. But in fact, the ureter does not look like it's had any sort of hyperdense calculus located anywhere. Let's go and have a look at the other side, all the way from the very, very top. So now we come from the very, very top here, and we can see the ureter is sitting somewhere within this region. There are some that do have stones, so it's entirely possible they've got a renal calculus that is causing their trouble. Right, so let's go down, 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 follow that ureter, follow that ureter, follow that ureter. And actually, it doesn't look like there's any calculus located within the region of the ureter either. So we've got to go back to square one, I guess, and try and figure out what's causing this person's trouble in the first place. So let's go from the bottom here, coming upwards, 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 upwards. And the thing about the sigmoid colon, it can be very, very mobile, right? So following it up, coming up to around here, we'll come all the way up down to here, is it? Feels like it's coming back down. Just about this way. Yeah, look, here it goes. There it is. So it did come back down. So it went all the way back, all the way up here, then all the way down like so, and then became the sigmoid colon again, and then turned back on itself, and then became the descending colon. And it's in this region over here, can you see, it looks very, very inflamed. And so they do have some diverticular. You can see a few diverticular sitting over here. So this looks like it's going to be diverticulitis. So one of the important negative findings for a diverticulitis is a perforation, or is there a collection? So this doesn't look like there's a perforation. It doesn't look like there's a collection. I haven't seen the free air anywhere in this initial look, but now we're going to go to the lung windows and have a good look around here as well, and try and see whether there's any locules of air located anywhere within the vicinity. So it doesn't look like there's any locules of air within the vicinity. So we go away and say, you know what, I think we're okay. This person hasn't had a perforation at all. But now when you come up to the upper images again, you may even spot it when you're doing a lung, you're having a look at the lung images, that there is some radiolucency over here and here. So that's lung, that's diaphragm, that's air. And that is air is sitting all the way up in the upper abdomen. And coming further down, you can see more locules of air located over here. And now you kind of spotted one, you spot like a whole load of locules of air all over the place in the upper abdomen. And so the only pathology you really have is that diverticulitis, right? But then all the air is located within the upper abdomen. So have they had a perforation, or is there another perforation? Could there be a duodenal ulcer that's kind of come up here? The duodenum is actually completely normal in this study. And what actually happened is this person had diverticulitis, and they basically sat at home with it for as long as they could. And then they perforated and sat at home with it for as long as they could. And then it sort of self-sealed itself. But that air that did escape ended up sort of coming up to the upper abdomen. And so they're trying to walk around and doing, maybe even sitting up with the pain that they had. And all the air kind of ended up coming up to the upper abdomen. So I think this is a really good case, because it feels like it's just going to be a normal case of diverticulitis, no perforation, no collection. But again, by doing your checking of doing the lung windows and the rest of it, you start to notice that there is some extensive amount of free air. So the person did have an extensive perforation, and it's possible that they've ended up sort of auto-sealing itself over time because they basically avoided coming to hospital for as long as they could. So this case is another trauma case, and this is someone that ended up being in a car crash. They were the passenger, and it was a quite significant speed. So let's have a look through. So this is a trauma study. Going through, we haven't seen anything grossly abnormal on the first instance, but now, yeah, there is what looks like some material that is located within the upper abdomen.